Another reason Gwen invited me to participate is because I have a personal experience as well. That's me and my husband, Matthew. I was a caregiver for Matthew for about 5 years when he had cancer. And, you know, I think we were talking today about trust and identity. Being a caregiver became my identity. I was in my 20s. We were dealing with, at some point, metastatic disease and end of life. It really overtook everything. I had a first career in television. It changed my career. It changed the way I thought about the trajectory of my life. And, you know, it was kind of all hands on deck to get him through treatment and whatnot. So I did one of those personality tests recently, and my first characteristic was helper. My second was reformer. So after my helping for a while, after he died, I went back to graduate school, got my MPH, completely changed careers, went into health policy, and really kind of carved out a niche of really helping patients engage in the design and delivery of healthcare. The next photo, which is going to be really hard for you to read, this is just an example of, in a way, what it's been like to kind of enter the health system in this new way, trying to affect change. This was sent to me by a change agent among a clinician friend of mine who kind of took this picture on the sly in a health system where they were trying to do a patient experience effort to improve the patient experience. So they installed these chairs in the emergency department so that clinicians, you know, with the data, looking your patients in the eyes, getting on their level, can really improve conversations, trust, et cetera. And so they installed the chairs with all good intentions, but I don't know if you can read it, but there's a sticker that's pasted on the bottom of the seat that says, physician use only. And so there's, you know, these chairs that exist in the emergency department treatment bay where there's no chairs for the family, and so I think, you know, the way I see my role is, you know, I think this was done with the best intentions. And I think when you have the voice of those who are on the other side, we can sort of help translate those good intentions so that they're received in that way. And then my last photo I'll show just because, I don't know, I'm proud. I think I just want to show it. But I can make it into a metaphor. Sometimes this is a really tenuous position to be in when you have this very personal experience and, frankly, trauma from an early experience in the system, both from the disease itself, but also from your experience in the system. It can feel very precarious. It can feel very at risk. I felt that way. In that situation, that's me rappelling in Greece from the side of a rock I had just climbed. And so, but at the same time, I had a support. I had the rope. I had my boyfriend who was encouraging me the whole way. And frankly, I was proud that I did it. I was happy to put myself at risk because I feel like there is a bigger goal at stake. And I think that's what drives most of us here. So I'm really pleased to introduce my co-panelists and for the discussion today. We're going to pass. We all have kind of photos that we prepared to kind of talk about our story. So I'll introduce, and then I'll pass down the line and ask each of the panelists to kind of tell their story, what brings them here today. We'll have a discussion, and like the rest of the sessions, we will have some Q&A at the end. So first, to my right is Mercy Adetoye. Mercy is a third-year medical resident in the Department of Family Medicine at the University of Michigan. Michigan has a big presence today. We have Kayla Cooper, an intramural research trainee award fellow at the National Human Genome Research Institute at the National Institutes of Health. And then Karen Moore, a patient advocate and the founder of the James D. Moore Memorial Foundation for Sepsis Awareness. Join me in thanking them.
Thank you so much, Michelle, for the great introduction. Like she said, my name is Mercy Adetoye. And here's my story. So I was born in Nigeria and emigrated to Colorado directly from Nigeria because my dad was a soccer coach at the University of Denver. So that's my father and my younger sister and I. Growing up in Colorado, I never saw any physicians that look like me. Who knows what the impact of that is? Does that mean that, can I be a physician? Because there's no African-American female physicians that look like me. But my dad would always say, you can do whatever you want. You're a princess, you're a queen. So that's the environment that I grew up in. Then, growing up in Colorado, I ended up going to the University of Wyoming on a soccer scholarship and spent 7 years in Wyoming, playing soccer and getting my master's there. That was where I learned that it doesn't matter where you're from, people will try and put you in a box. This is where I learned that I actually am Black in America and what that means. And then afterwards, I transitioned to Seattle and was a high school teacher in Seattle. One theme you'll see throughout all my photos is that I always had natural hair. It was either in braids or my fro as I'm wearing it now. If you look at the folder, I did this on purpose. My professional photo is me with a weave, which is long, sleek black hair. Because when I was transitioning from medical school, I went to medical school at Michigan State University, into residency, the question was, when I went on these interviews, were people going to see me in my fro and think I was Angela Davis, angry Black woman that was going to make things difficult? Would I fit into the profession of medicine with my natural hair? So I made the conscious decision to wear a weave, although it wasn't necessarily the way that I like to present myself. It was just knowing that I needed to get the job first in order to be educated in that way. Since I've been in residency, I have really thought about that, and I'm a big picture person and thought about ways in which the system could make it so the onus and the responsibility is on program directors, it's on, if you want to recruit and retain minority candidates, they should do the work in terms of thinking about what would make somebody that is considered other feel comfortable in their system.
Hello, everyone. My name is Kayla Cooper, and I am a Intramural Research Training Award Fellow at the National Institutes of Health and the National Human Genome Research Institute. But as Mercy just stated, I'll be going through a little bit of my story as well. So growing up, I faced a variety of health issues that, while they persisted through my childhood and adolescence, they actually didn't really get cured or really diminish until my college years. And I didn't really think about what trust meant in those relationships and how that manifested throughout my childhood. But now just sitting here and thinking about trust, how it's so important to have that trustful relationship between patients and providers and how much that means to me today. And I use my own personal experiences to pursue a career in medicine in the future, starting next year. But one of the first times that I was able to see trust was when I went to the Dominican Republic on a medical outreach internship during my college years. And on the left picture, you can see me with one of the patients. I'm doing her blood glucose there. And on the right side, we taught classes on dental hygiene to young students at a local school in the DR. But what I really saw in the country when we set up these clinics throughout some of the most destitute areas of the country was that despite the fact that they did not have access to a lot of the medications or to health education, what they did have was that trust. And that's trust in the local physicians there, but also in the nurses there, and just in the health system in general, and how important that was to have this trust. And so when we had these clinics there, we gave free medications and we provided physical examinations for the patients there. But what really made those sustainable health changes and really made us able to make a large impact for the patients there was, again, that trusting relationship. And this is kind of where I cemented my desire to be a physician, but also to continue the research efforts that kind of came after my time in the DR. So I started a project where I tried to see how migration and individuals living in Spanish-speaking countries, what that really meant for their health and their health care. And a lot of times I found that through interviews, but also through analysis of the medical records of these individuals, that sometimes because of that migration, they don't have a lasting relationship with their physicians. And because they don't have this lasting relationship with their physicians, they're not able to have those health outcomes that they could if they had that longevity within their relationships with their patients. And so hoping now, as I enter very early in my career, As I mentioned, I'm currently a research fellow, and this is just a few individuals in my lab who I'm just very blessed to be within the Bonham Lab, but some of our projects that we're working on really try to look at low resource individuals and specifically individuals who are in the sickle cell disease community. And in the sickle cell disease community, we're looking at the clinical phenotype and we're looking at the genomics as well as the psychosocial data and getting kind of that bird's eye view of what do all of these different pieces mean in the puzzle to manifest into what it means to have sickle cell disease, since it looks so different in different patients. But I'm here today just to share my story and open the conversation about trust between patients and providers, but also trust between researchers and research participants, and hoping to pay it forward as I enter my career in the field of medicine and research. So thank you.
Good afternoon, everyone. My name is Karen Moore. I am a retired wedding planner. I was kind of thrust into this. In 2009, I lost my husband, my best friend, my business partner, my soulmate, and everything else in that one individual. And I thought that I would grieve, I would move on, and kind of pick up the pieces to my life and make sure that I got my son where I needed him to be. In 2016, I found myself very ill. The same illness that took out my husband, I became septic. So it became a fight for my life. And I wasn't quite sure if I was going to survive. And after I recovered, I was able to move forward, and I started making some changes in my life. And I started looking at my health and how I took care of everyone else, but I never took care of myself. I'm also a caregiver. I've been taking care of my mother since 2008. She actually came to live with us about 5 months before my husband passed. So I thought it was, he decided to leave me hanging, And so I had a very difficult relationship with my mom, but needless to say, I had to step up. So in 2016, after I became ill, I started to look at my life and look at where I was and what I wanted to do and what I wanted to be. And it just seemed like everything that I had accomplished prior to that, it didn't matter any longer. So I went on a quest, I went on a journey to improve my health, improve my well-being, and I'm trying to get my slides. This was actually taken in Newport Beach, California in April of this year. That was the first opportunity I had to tell my story. And every time I get a chance to speak, it's always emotional because it always takes me back to May 5th, 2009. But needless to say, I'm here and I have a voice. And I want to use my voice to make sure that no one else has to walk the path that I had to walk. I'm here because my husband no longer has a voice. I'm here because so many people that I've had the opportunity to connect with have lost parents, husbands, children because of sepsis. So it is now my mission and my passion to make sure we start to minimize that. So I had the opportunity to fly out to California and be able to share a little bit of my journey with Edwards Life Sciences. And this picture was, they had their employees that really just greeted us and really made us feel loved and really made us feel that our stories mattered. And that was the first time that I realized, and I had that epiphany, my story does matter, and what I have to say does matter. So this was me sitting on a panel discussing, again, my journey, my path with sepsis, what I look to do with sepsis and making people aware and becoming a mouthpiece for advocacy. I'm now working in Georgia, making sure that Georgia becomes sepsis safe. I'm working with our lawmakers, and I will not sleep. I will not stop until we have mandatory protocols in Georgia to make sure that families are protected. So this was a part of my journey, my story, as I was able to share with this particular panel about my experience with becoming septic and, of course, losing my husband in the process. This was a pivotal moment. I had an opportunity to share my story once again on Capitol Hill at the Patient Congress. So I have to thank you, Gwen, for inviting me to come back to share with you all. So this was actually taken in September, and it was, of course, another emotional moment, but it was a necessary moment. And that's it.
Thank you, and thank you all for sharing your story. And I want to stay with the stories really quickly, because I think, you know, for many of us, our motivation for change really is born out of pain. And while we are attempting to transform that pain into something bigger, I think it's important to kind of note where that moment and those moments and how they have affected your thinking. So I'm wondering if any of you can identify a moment where you felt like either your trust was betrayed or where there's a blind spot that sort of really made you realize. So I'll tell you, in my experience, my moment, the first one where I became really clear that, oh, I'm going to have to take this in, you know, the system may not be designed to protect me here, was my husband was having his second round of radiation. He had a prior one in his shoulder. This one was going to be in his hip. And as we're talking to the radiation oncologist, mind you, I'm 23, and I think he's 26 at the time. And so I sort of raised my hand and said, hey, do we need to worry about fertility? And his radiation oncologist replied, I don't know. And I we were supposed to start radiation in like a few days. So that was kind of my moment of, I mean, it really was sort of, and then after he said that, my mind flashed back to the waiting room, which was all men in their probably 70s. I have a feeling prostates. And I realized, oh, wow, this didn't even occur to him. And if I'm not sort of more actively thinking about these issues, it may be too late. I may, you know. And so that was kind of a moment for me that was activating in the process. And I'm wondering if any of you can talk about a moment that you either returned to or that really impacted you in thinking about the career trajectory you've taken.
Yeah, I can speak to that. So as a trainee, I've learned a lot from my patients and patient interactions. So I had a patient interaction. I'm a family medicine doctor, and I totally think family medicine doctors should deliver normal, healthy pregnancies. But this particular patient comes into labor and delivery, and we present all of the patients, so all of the OB providers, family medicine providers, our midwives, everybody is aware of what's going on the floor. So this patient was presented as a female that came in, and she only wants African-American female providers, which is strange because it's normally, I only want Caucasian providers. So this was different, and so that's the way it was presented. And then later, speaking to the patient, she actually said that the reason she wants African-American female providers is because she heard of what happened to Serena Williams and the fact that Black women in pain and labor and delivery, they die more frequently than their Caucasian counterparts. And so she was afraid that nobody would believe her, and she'd end up having a C-section and dying, and her baby would die. But the only way we could get that information was because I presented, was vulnerable in that moment and said, hey, told her about my life experience and asked specifically what she was looking for. And that completely reframed it for me. It was born from fear that I wouldn't be heard. So when I think about as a trainee and kind of activating moments, I am all about thinking about how do you train culturally competent residents so that even if you don't look like the patient, you can go the step ahead and say, hey, we have a very diverse group of providers here, physicians here. We can't guarantee that you'll get exactly this, but I hear you, I see you, I understand. I will try to understand the reason that where that question comes from. And so that was something that was very, very incredibly activating for me.
Kayla or Karen?
I think I lost trust in the medical system when my husband died. And it was kind of a up and down. We had a really great family doctor. Our primary care physician was absolutely wonderful. And we had a wonderful relationship, and we trusted her wholeheartedly. But when you go to the emergency room, that whole platform just changes. And it was, I trust her, but I didn't trust anyone else. And it wasn't until I became ill that I started to look at the medical system, and I even found myself comparing my level of care with how my husband was cared for. And so it's something when you take medical records and you just have pages and pages and you're going line by line trying to figure out what happened. And so for a long time, I didn't, there was nothing a doctor could tell me. And I was channeling that anger in the wrong direction. So after I healed and I went on my wellness journey, I went back to those medical records and I started approaching it from a different standpoint. I started looking through the lens of the doctor and the challenges that they face. And then I also started to look, well, Karen, you didn't ask the right questions. So at that point, it became, you need to now learn how to be an advocate for yourself. You need to learn how to ask the right questions and not just sit and just be passive. So the experience taught me that it was time to take my health into my own hands. Yes, we have the physicians, but I am ultimately responsible for my health and my well-being. And that was kind of my, that moment.
Yeah, I can also speak on from our research that we've had in our sickle cell clinical trial that a lot of times our patients come with us, we give a slew of psychosocial survey measures to them to administer, and sometimes a lot of our patients feel a sense of medical mistrust, and especially for sickle cell patients, as Kellen mentioned earlier, a lot of times when they go to the ER, they're seen as drug seekers, or they're honestly not even seen because a lot of times it's what you see, but it's almost, for sickle cell patients, it's what you don't see. It's more of sometimes an invisible disease where individuals may have this pain, but they may not outwardly show it. And so I think specifically for the healthcare system that is supporting these patients, I think it really opened my eyes to the awareness of disease and what that really means in education for providers and for patients themselves on how to explain their disease to providers, but also for providers to look beyond symptomology and how that can translate to health outcomes for patients specifically who don't have that outward appearance of their symptoms that we've seen.
Great, thank you. And I think, we have a kind of interesting mix on the panel of people who come from sort of more of a patient or caregiver experience and then those pursuing a career in medicine. And I think, we often kind of think about the sort of these issues in terms of kind of where clinicians and patients are at odds or where it goes wrong. And I'd like us also to think, and I think we've heard a bit about this and how to build trust, in the discussions earlier today, but, I'd like to hear you all think about from your perspective sort of how we can harness what clinicians and patients have in common and how what we want out of the encounter that may be common ground. And then, you can also kind of talk a bit about, the tensions there from your perspective. Again, I think we're sensitive to clinicians and feeling burdened, right? And I think patients feel that too, on the behalf of their clinicians, right? So can you think about kind of what is common grounds that we can find here where we can make progress, but are there tensions there in getting there?
Well, I'm a resident, so lots and lots of work and lots of time. I think about what patients need, and they want to feel like they are people. They want to feel as though you see me and they are being heard. And then I think about my life as a resident and being a clinician, and what patients need is 24-hour access. But as a clinician, I feel the tension of how do you offer 24-hour access when physicians are people too? And a burnt out, not well physician does not provide good quality care. So that is the tension piece there. But what underlies that is that we're human beings. And so what I want in an encounter, and family medicine, we're touchy-feely and we want to take care of the whole family. I want time. And I want connection, and I want a relationship. I want you to feel heard and seen, and I want to be seen as well. I want to be able to share that, hey, this great thing happened in my family, and this is what's going on, and I want you to feel comfortable there. So I think the underlying piece is that relationship and that connection, and that is a mutual thing that we both want out of that 15-minute clinical interaction.
Yeah. Karen or Kayla?
I would say, speaking again more on the research side, I think sometimes there is a tension between someone's research agenda, but the community's agenda and the community's needs. And there's a lot of times a discrepancy between those two and a tension between the two. So I think it's really important to have kind of a merging of what's the research timeline, but also what can actually be done within the community, and trying to match the goals of the community and the needs of the community with the research agenda, and making sure that researchers are recognizing that conducting this research is a privilege and a gift, and something that really cannot be taken for granted, especially just with historical trauma and historical research projects that have not been utilized for the best of the patient interest or the community interests. And so just making sure that there's a streamlining of the research agenda and the community needs as well.
Yeah. Karen?
I have to agree with Mercy. At the core, we're human. And we both, from the patient and the clinician, they both have needs and different things that are pulling on them throughout the course of the day. So I agree. I want to be heard, and I want to be able to know the clinician or the physician that I understand that you have your set of challenges as well. And I want to be able to create that atmosphere where it's safe for both of us. But I don't want them to come in and just assume that, from a 5-minute interaction that you can sum me up in all the things that I am experiencing at that moment. So I think a space where both can dialogue and be mutually, respectful of one another, and be able to come together and co-create something that's going to work and be beneficial for the patient.
Yeah, and I think some of you kind of touched on this, where those tension points are, and I think we've talked today a lot about the vulnerability in play on both sides when you make yourself open to building trust. I think for those of us who have taken personal experiences and sort of work on these issues now professionally, and just as we go about our careers, I'm curious to know what you all do to take care of yourselves. This work is hard. This work is personal. And I think not only what do you do to take care of yourself, but what do you need from the system, from where you're training, as you think about going into training and into this system. You know, how do we make space for that, and what do we need to support that?
I like big picture questions. I think that from the system, medicine is such that it's a factory line. We are supposed to take somebody, doesn't matter what their background is, put them through undergrad medical school, medical school residency, and then create this professional, this physician. And inherent is the lack of understanding that not all of us have the same background, and we don't all need the same thing in order to be successful as a physician. And even this picture of what that professional, my long hair in the suit looks like, can we shift that a little bit so the definition of a physician can be a lot of different things? And so what I need is, and what my program director does well, is recognize that coming into residency, I was an entire adult before, and so what I need in comparison to some of my colleagues is a little different. And then a little bit of space that allows for time to just reflect on the experiences that we go through. So for instance, the labor and delivery experience, the first time a patient passes away that you've been taking care of for a month, space in which you can reflect in a way that does not feel as though you are weaker because you're vulnerable. So that's the self-care piece. I spend a lot of time, we are allowed in our program to reflect. So,
Karen or Kayla, any thoughts come to mind?
I guess since I'm very early on, I've just taken a very methodical approach to how I see myself as a future physician. And I guess when speaking with other physicians and asking for advice from them, I think there's always a sentiment of trying to navigate the healthcare system yourself, and trying to putting myself in the future in the patient's shoes. And so I guess right now I've tried to just seek out patient narratives and trying to understand their perspective so that once I'm in that place, I'll be able to recognize some of the tensions and some of the qualms that they have with the system, and using my ability to kind of change that narrative and change the way that they see themselves within the healthcare system, but also making them feel empowered in their decision making and making them feel that they are vital members within their health, and that they should feel empowered to be able to have those conversations with me as a future physician, and just making them feel that they should be within that conversation as well.
Mm-hmm.
I think for me, from a standpoint of a patient, I need compassion, and I need empathy, and I need to be heard. And those, I think, are the big things for me.
Yeah. What do you have any thoughts on? I think for me, one of the important things as well, and this has come up as a theme many times, is community, broader community. I mean, in the sharing of experiences, have you, for example, built community around you that supports you through your training, or Karen, through your experience?
I do have a community that I have built that has been able to walk with me through this entire journey since 2009. And having a support system where I can go and, just let off steam, whether I just need to vent, or I need to share something, or something has happened in, the world, of sepsis as we know it. So having that support system, and even to help me, because again, I am the caregiver for my mom, to be able to come in and say, okay, you need some time away. And so for me, that has been quite beneficial, because a lot of times you feel as if you just backed into a box and you can't see your way out because you're being pulled in so many different directions. And now what I'm finding, because of my experience, I have people that look to me that are constantly calling or inboxing, because now they're finding themselves in a position that a relative has become septic, or someone that they know is septic and they need some understanding, they need clarification, they need to find out what to ask the doctor. So I'm finding that having people around me to kind of help me, give me that support, because I'm still fragile in some areas. So having that support system, and even my primary care doctor, we had talked about being accessible. And I know that if it boils down to it and I need to reach her, I have her cell phone number. And so for me, that is huge. I won't overextend my bounds in calling her all the time, but I know if it's a dire emergency and I need to talk or just release some steam, that person is there for me.
I think we're all fragile, right? That's one of the things
Absolutely.
Yeah.
It's interesting I don't know why I thought this. Coming into an ivory tower institution, I thought that it would be better prepared to support a minority resident. And I love my school, I love my program. But I was surprised at the idea of the idea of inclusive teaching or recognizing that there was somebody that was other in the room it wasn't automatic. And so during my first year, because of the stresses of residency, I didn't seek out kind of that professional support, that sense of community. I had all of these women behind me that are physicians in Michigan or professionals in Michigan that became my village, and that is who I would get the support and the rejuvenation I needed at home and from my friends so that I could go into the professional world and kind of steel myself and present myself as the way that a physician should be. And it took a long time for me to realize the importance of having a professional community as well. Mm-hmm. And unfortunately, because of the way that its system works right now, it took me seeking that out and having the reserve to be able to go out into the world and say, hey, are there other people that look like me? Are there other people that are considered others? How have they navigated the system? Because I do think that as a minority, I deserve to be in an ivory tower institution and get this education. There are a lot of residents that are minority residents that don't make it through residency. A lot of African American surgery residents will drop out of surgery residency, and I think part of that is because that support, that professional community is not there, and the system still expects that the resident, the trainee, would go out into the world and seek that. So I consider myself lucky that I have a whole bunch of very powerful women behind me that are like, you can do it, it'll be fine. So, yeah.
Good. So I'm going to turn to questions, but I think in order for us to have done our job, I just want to ask, because I think we've heard a lot or already on some themes of what we need in the system, things about space for reflection, time to build these clinical, relationships together, support community, but in kind of thinking in the future, sort of changing and driving the future and creating a system and co-creating a system that we want and need. Is there anything we haven't covered about what we really need, what we need to accomplish to co-create a system where we've got trust and can co-create medical decisions together? And we'll go to Q&A.
I feel as though one thing that I haven't mentioned yet is that the patient population is ever changing and becoming more diverse. I'm a patient. I've been a patient. I will be a patient again. Is becoming more diverse, but our leaders have not reflected that. And I think part of the future and improving this is having a whole bunch of diverse perspectives at the table so that we can help take very good care of an ever-changing population. Yeah, I think that would be huge. Yeah. So.
To jump off that, I think also looking at patient populations not monolithic in nature, but that they are very individualistic in their symptoms or in their culture, just all of the things that have to do with their health, that they're different. And making sure that we are able to meet the needs of those communities and those patients and the diverse set of characteristics that they bring, and making sure that we're treating more broadly rather than just saying, oh, well, this patient fits this kind of narrative and therefore I'm going to diagnose them or treat them in this manner, but more so having fluidity in the way that we are treating the patients that we serve.
For me, I think it would be health literacy and working with patients and help to empower them so they know the questions to ask and they begin to take responsibility like I have for their care. I think those type of environments are needed now from the clinician side, more sensitivity training, a little bit more compassion, and being able to just kind of bring them together, that it is a partnership.